And I can't tell you how many codes that we've gotten ROSC just because we found the underlying cause that I personally believe would have never found if we're just sitting there with like a laminated card just trying to read things off. It was the ultrasound that saved those people's lives.
Hey everyone, Paramedic Coach here, and we're back here with another podcast, and definitely got another treat for you today. On the podcast today, we're going to be talking about a few different topics. So we're going to be talking about cardiac arrest, we're going to be talking about some airway stuff, some critical care stuff. And without any further ado, I want my guest here to kind of introduce himself, and we're going to dive right into the podcast.
Hey, what's up, everybody? My name is Haney Mallemat. I'm an emergency medicine and critical care physician in South Jersey. It's really an honor to be here. Thanks for asking me to be here, Evan.
Oh, of course. So kind of how we met, one day I'm scrolling on Instagram, and Haney here pops up. Amazing tips, amazing insights. So you're actually my second guest here on the podcast. So had to get you on here. And I think it was one of your videos talking about intubation that really perked my interest. You were talking about, ways to go through the structures. And I'm like, this has been really awesome content. I started learning more about you. And I'm like, all right, we got to do a podcast together. So first question I got for you here, let's just, kind of get you introduced to my audience. So kind of, what was your story getting into, emergency medicine, critical care medicine, and kind of where you're at today?
Emergency medicine came almost by accident in medical school. It's a long, boring story, but I was looking for something that I could make an impact with patients immediately. I was looking for something where I could do a lot of procedures, use my hands. I actually wanted to do surgery first. And then I started hanging out with that culture of surgeons, and I just, I realized that it wasn't for me. And so emergency medicine seemed like one where you could get all the procedures, have people that were just kind of like me. Nothing against surgeons, they're just not my personality. And then as I was going through emergency medicine, I realized that I wasn't getting the longitudinal relationship with patients. So great, you save a life or you do something amazing in the emergency room, but I don't know what happened upstairs with those patients. I didn't realize what happens with all the aftercare, the mechanical ventilation, weaning off the pressors, the antibiotics, the end of life stuff. And I started to investigate what critical care medicine was. And I was like, well, that just seems like an extension on the spectrum of what I was doing downstairs and getting it done upstairs. And unfortunately, or fortunately, I'll say fortunate because I think everything we do has a reason. There was no pathway from emergency medicine straight to critical care like there is now. So I did emergency medicine combined with internal medicine for the purpose of going to get my critical care boards. And so 7 years later, after all that training, I was able to be an emergency medicine physician and a critical care physician and do those both as part of my career.
Wow. So kind of building on that, what kind of piqued your interest the most? Was it just kind of like the curiosity of like continuing care, or what kind of made you kind of make that step?
It was a lot of things. The basics of it are I just wanted to see disease all the way through. And in emergency medicine, what I noticed with a lot of folks is that they're always chart biopsying to see what happened to their patients upstairs. And I always see the emergency physicians, when they see the intensivist, say, hey, so what happened to that patient I admitted yesterday, or what's going on? And it just seems like there's such curiosity. Why not just be part of that? And so that's why I went to critical care for me. And the other part that I didn't get too much of was the family interaction, the patient interaction, the dynamics, whether it's a patient who lives and survives or a patient that ultimately goes on to end-of-life care. I didn't get to see that. And it was important for me to help work with families as a social part of medicine. And so for those reasons, critical care satiated that need that I wasn't getting in emergency medicine.
As a paramedic, obviously I totally get that too, right? So, we're dropping off a patient. And then same thing with the emergency medicine, staff are always asking, how's the patient doing? What's going on? So when you first said that, it totally clicked to me because I was like, that's how we are as EMS, right? We're with a patient maybe 10, 20, 30 minutes max maybe, and then it's over, we're on to the next one. So you're always curious what's going on. So I think that actually makes a lot of sense how, someone working in the emergency department can say, okay, I've done this and now I want to go into critical care and be kind of at the end of it, like end of life stuff. You get into that too, and all the seeing the more of the patient presentation and kind of unfold, and then you're at the end of it. So that totally makes a lot of sense. So that's awesome. So I gotta start with a few things here. I wrote down a few tips and even a few things that I know you as a medical doctor my audience would want to know about? My audience is primarily EMTs, paramedics, a lot of students, stuff like that. So the first point I want to touch on here that a lot of people ask me is when we're giving a report, right? So we're paramedics, we're going to the emergency department, we're kind of giving a report, or even in your care, let's say you're going doctor to doctor, giving a report on a patient. What are some pearls, what are some tips that you kind of look for when we're giving a report to you or you're getting a report from somebody else?
The thing that I notice, now I'm looking back at like a 10-year career of being an attending, so I have a little bit of perspective there. The one thing that I notice consistently that happens whenever there's handoff, whether it's paramedic to ER, ER to ER, ER to ICU, is there's so much adrenaline that's pumping in the moment. You have this sick patient, you've done an intervention, either that intervention's successful or that intervention's ongoing and the patient's still unstable. There's this adrenaline that's pushing, and our natural inclination is just to, bring the patient in, start talking, because we don't know what to do with this energy. And that's a problem. It's a problem because when the patient comes in the room, for me in the resuscitation bay, I believe that what we should do is we should get the patient over to the stretcher, transfer all the monitors over, make sure that that patient is okay. And then when everyone's heads are cool, everyone's mind is cool, we have a fresh set of vitals, that's the point that we need to start doing the handoff. Because if you're doing like the one-handed chest compressions, pushing the patient over to the stretcher, nothing on anyone, it's just, I don't think people take the time to take their own pulse and say like, this is not really a good situation. When we've done video review with paramedics and even emergency physicians, they're like, yeah, that doesn't seem like a very good handoff at all. So take the extra 30 seconds to put the patient on the stretcher, transfer everything over. And then when the entire team is focused and ready, then let's listen. Because oftentimes I find that the head paramedic is looking at me, giving me the report. I was like, yeah, but what about the respiratory therapist? What about the nurse? What about the resident who's running the airway? Everyone needs to get the sign out. So I think everyone has the capability of doing this. Just taking your own pulse, transferring the patient over. Let's get the story in full detail, and then we can continue on the resuscitation.
100%. And I think if every recess room was kind of run like that, I think everyone would be better off, So that was literally hit the nail on the head with that one. I couldn't agree more on that, So no, that's awesome. So that's point one. That was fantastic. So second part I want to get into is kind of building on that. I want to get into some of the I would say probably the two main skills as a paramedic, and again maybe some pearls, some tips. The intubation one, we'll definitely go over that. That was great. So we'll start off with one of the main skills we do in EMS, which is IV access. So in your career, what are some some tips, some pearls you have on IV access, and what we can kind of learn from you as paramedics?
I don't. Honestly, I'm being humble here. I don't know how much I'm going to impart of wisdom. You all are bouncing around in a rig that's going 40, 50 miles an hour, trying to hit a vein. There's not much I'm going to be able to tell you with regards to that. If you get access, I'm just impressed with that. What I will say, and this is changing in more and more systems, is that after one or two pokes, it's time to go IO, especially for the person who's unstable. In our system, I'm lucky. I see that a lot. In other systems, not so much. And I feel that that is a place where we can do a lot of improvement for. Even in the hospital, to be honest with you, I see people who are trying to put central lines in during a resuscitation. I'm like, what are you doing? In 5 seconds, you can have a central line rather than kind of dicking around in there and risking needle injury and also causing other complications. So if there's any pearl, which, your audience is a highly trained group of people, it might be to go to IO if you're not doing it early already.
Yep. Actually, I've talked about that before too in some of my videos as well. It's like, I never understood that, especially with a very critical patient. It's like, if you can clearly see there's no access, it's like, don't waste time, man. Like, if the patient's that sick, where you're even thinking about doing the IO, it's not going to hurt just to jump into it. You can always play around later if they get better. So I completely agree with you.
And you put anything you want through the IO. There's nothing you cannot put through the IO, and it is a central line. I have to keep saying it because people don't think of it as a central line. It is a central line. And in fact, the only time I can think of where you wouldn't put an IO, when I say IO, I'm sort of generically saying tibial, but we all know you can go humeral. There's sternal, although I don't love the sternal IOs, even though the data is good on them. It just looks weird. It just looks crazy. But the only contraindication I would think that you would go for humeral first, and not tibial is if you have somebody who is like a severe trauma patient, where maybe there's some intra-abdominal injury and the pelvic veins are bleeding, or someone who's pregnant and severely gravid, where you may not get that venous return back to circulation as quickly as you think you would. So then I would go humeral. And then there's some systems that do humeral all the way, and good on them.
So one point I really want to touch on, which is another main reason why I wanted to have you on. I'm always curious, like I had my last guest, like what's going on in like your neighborhood, like kind of what are you seeing, right? Your channel is kind of a lot about that. So we'll touch on that with the next point here. So obviously one of the main things that you talk about is cardiac arrest, right? So I kind of want to kind of peek into this, and we'll just start with this. What has been maybe something new in your system, or maybe some new research you came across, or something interesting you came across with terms of cardiac arrest care or resus, maybe something you've seen in your practice, maybe a case, kind of getting you going here. So curious what your thoughts are with that.
The things that I don't know how new they are, but I like our system. Our system has a great medical director and really focused on really up-to-date training. I like the fact, starting with the A's, is that, folks in the field, unless there's an obvious airway obstruction or an aspiration, is going for supraglottic airways. And they use iGels, and I don't get paid by iGel. It's just the device that they use. And it actually works very, very well. And there's some studies that say that even paramedics prefer iGels to intubation, at least one study I can think of. So I like that people aren't messing around in the field trying to do intubations. I think there are times where intubation is necessary, but putting an iGel in cardiac arrest, to me, focuses on chest compressions and defibrillations, and gets people doing other things that they need to be doing when they're coming to the hospital. The other thing that I like, and this is somewhat controversial, is the use of mechanical CPR. This is one of those hot topics in pre-hospital and even in emergency medicine, where people, they'll fight really hard to say why we should be using mechanical CPR, and they'll be fighting to say why you shouldn't. For me, simply, the reason why we should be doing mechanical CPR is because it just quiets the room down, and it also ensures that there's consistent compressions happening. Again, I was teasing a little bit before when someone's coming with the one-handed chest compression, or they're transferring people over. I don't think there are times where we're much better at chest compressions in the hospital. I oftentimes have to correct people about the depth, the rate that they're doing, they're slowing down, or, they're kind of looking over, seeing if it's time for a rhythm check. Mechanical CPR gives you the same chest compression fraction every single time, the same depth with the same accuracy. Yes, you have to worry about migration of the plunger to make sure you're not causing any intra-abdominal injury, but the level of quiet consistency that you get with it, to me, outpaces anything. Other thing is IOs. We already spoke about that. Getting early IOs early. Don't mess around during a cardiac arrest with trying to place a central line or even a peripheral line. Just do an IO. And maybe the last thing, which might not be for the pre-hospital folks, but I do like to teach what we do in the hospital so that everyone pre-hospital gets a sense of what we do, is I think getting an arterial line in, a femoral arterial line in, is really important during cardiac arrest because, well, there's a couple reasons. The first reason is it's just more accurate than a pulse. Feeling for a pulse, you can look up at the monitor and see what there is. Secondly is the blood pressure. There are some times where you have pseudo-PEA. The person's actually not in arrest, but they just have a really low blood pressure. They're in severe shock. An arterial line will tell you that. And then finally, in many systems, you're coming in and you might do VA ECMO, and having an arterial line in the femoral space will allow them to put a wire back in and recannulate and get things, cannulated for that VA ECMO. Yeah, I think those are the things. And tidal CO2 is another thing I think that most pre-hospital systems are really good with, but we need to be doing more of that. It's a vital therapy, help guide your chest compressions, and also the dosing of your epinephrine. And we can talk about any one of those in detail. Sorry, I'm rambling, but I'm passionate about this stuff.
By clicking in the first link in the description, you get lifetime access to my Video Vault program. The Video Vault includes over 480 videos of content and now holds over 2,000 National Registry practice test questions. Is exactly why I wanted to have you on. So that was perfect. So let's talk. This is actually perked my interest up here. So let's talk about this. So you mentioned how going in, getting an arterial line. talking about that pseudo PEA. Now, my audience may not have even heard of that before, right? Obviously, we know if you're in cardiac arrest, really only 4 rhythms you can be in: systole, PEA, pulses, VT, VF, right? So, talk about that. Have you actually had patients that were in that rhythm, and you uncovered it? Like you thought they were in arrest, and then now they're back. Like, is that how you kind of found Rosk in that situation, or? I'm pretty curious.
And I'll clarify the terms, because I think actually
sure.
pulseless electrical activity is a pretty crappy term. You'll have to bleep me out. Sometimes I get a little bit
I know, it's all good.
curse-worthy. But I got to tell you that PA is a really sucky term. But pulseless electrical activity says that it's really electromechanical dissociation. The heart is electrically beating, but there's no motion. There's no pulse. The problem is that we, and I mean us, the house of medicine, pre-hospital, in-hospital, everyone sucks at doing the pulse. There are studies that show that people don't feel a pulse when in fact there is a pulse. And there are studies saying that people actually feel a pulse, but they're feeling their own pulse when there's no pulse happening. And this data is pretty good data. Also, the time to get a pulse is well beyond, for most people, that 10 seconds that you're supposed to be doing that rhythm check. So for that reason, this PA term and the use of the PA is really not so good. For me, I would much rather have an ultrasound probe. Now, to answer your question, have I ever had a situation where we did not feel a pulse and then we put the ultrasound probe on and we see good contractility of the heart? Absolutely. Someone who's morbidly obese, right? Someone morbidly obese, you're trying to feel a pulse. No one can feel a pulse. Well, it's because there's this much adipose tissue that's there. You're not going to feel a pulse, but I can see a rigorous heartbeat moving. And so what I would do is I put an arterial line in and say, oh, look, they're not well, their blood pressure's low, but they're not 0/0. Maybe they're 60/40, and there's things we need to do. The other time is if you have somebody who has pericardial tamponade. So now, okay, great. So you're going through your H's and your T's, you're thinking what could be going on here. There's no pulse, but you put the probe on the heart, there's tamponade. Why go through that whole algorithm of things when you look down and you actually see that there's pericardial tamponade? You should actually just go drain that effusion. So I think that, the ultrasound technology, I also don't want to disengage some of your listeners because they say, well, that's a hospital thing, that's a physician thing. I believe in the next 5 to 10 years that portable ultrasound will be on rigs, maybe not every rig just yet, but will be on rigs and will help patients pre-hospital to figure out what exactly is going on so we can tailor our care earlier on rather than waiting all the way till they come to the hospital.
I agree 100%. And there's some rigs, in case of like trauma where they're already on in some areas, right? You hit a good point. Not in every area, right? But yeah, there are some doing it and they're having like great results, like fast exams, stuff like that. Yeah. So, I mean,
the technology is getting so cheap. I mean, it's so cheap. I have here, look.
Oh, go for it.
I have a couple of these. I have a portable ultrasound just laying here on my floor in my office. This is how cheap the technology is. So
there you go. You never know you need it, right?
Right? Who knows? But my point is the technology is so inexpensive. I can't find a good reason that we're still using a stethoscope pre-hospital in a noisy ambulance or even in the emergency room when you have technology that's under $5,000 that you can actually look at the anatomy and look to see what the problem is. And I can wax poetic on this for days. I'm a huge ultrasound aficionado, but I want to bring home the point that this is not like a physician thing. Medical students are getting this now. Instead of the stethoscopes that they used to get, they're getting ultrasound machines. So why can't a highly trained pre-hospital provider be able to do that as well? And it's coming. It'll come.
I love it. I love it, man. I love it. So the next transition that I want to get into, that was some fantastic pearls there for sure, is I want to get into let's picture a paramedic. Maybe they've been a paramedic now for about 3 to 5 years. And not everyone, but usually around that point, you might have some paramedics that maybe they get an itch to get into critical care medicine or flight paramedicine. I guess I'd say, what are some tips for those people that they're thinking about getting into critical care, whether it's critical care transport or it's maybe they do want to get in part of a flight crew. There's also a lot of paramedics that even transition into flight nursing, stuff like that. So I guess, maybe some courses, some classes they could take, or just some pearls from you. What are your thoughts on that?
What I've seen, and I've been in some systems where I've interacted with a lot of flight paramedics and flight nurses. they seem to kind of go through a transition. I see them when they first start off as maybe like a tech in the emergency room or in the ICU, and then they go on to nursing school, and from there they transition into flight. So I think the most important thing is to be in it. I do see some people, and this is more on the physician side, but I think they just think that critical care is cool. It's really cool. It's like, I'm intubating all the time, I'm decompressing chests, I'm doing chest tubes and all that stuff. And any mature critical care paramedic, I think, will tell you, and correct me if I'm wrong, that those are the worst shifts. If you're driving in and you're intubating someone or doing a crike in the road, like, you want to bring your patient as safely as possible to the hospital and maintain their homeostasis as best as you can. Any shift where you're just doing tons of procedures, that means your patients aren't doing well. And I don't think anyone as a human being could like those shifts. But I will say that there's this assumption that, like, with critical care, whatever, it's so exciting. And I think with exposure to that, working shifts where you actually realize, oh, I'm not intubating every shift, I'm not criking people every shift, I'm not putting IOs on every flight. The people who really like critical care will stick with it because they're like, no, I just love the physiology, I love the resuscitation. And the people who realize that it's not all that they thought it was, they'll save themselves a lot of time and pain with going through that training and shadowing.
I agree with that 100%. So I wrote down another question, but I'm going to save that. So stay tuned to the end, because it's going to be about recess, but we're going to save it. It was one I was to ask earlier, but we'll save it for the end.
Right.
So next one I got here written down, I definitely wanted, this is how we kind of first got into your content too, was about intubations, right? So obviously there's a lot of new medics on my channel that are just kind of learning intubations. Part of your, paramedic, clinicals, if you will, is you have to go into the OR. You have to, they have cases. You have to go in there, intubate. Depending on where you're at, you have to get a certain amount of intubations, whether it's in the field or whether it's in the OR, to actually get your paramedics, certification, license, all that kind of stuff. And obviously that's one of our main skills, right? RSI, doing that out in the field, all that kind of stuff. So especially more in rural areas, you see more of the RSI stuff too, right? Because you're far away from the hospital and you got to take action, right? So what are some tips for intubation for paramedics or someone maybe just learning for the first time?
One of the biggest things that's important is to learn with video first. And this is something we were actually debating last week on social media, is how good is video? Should video be the standard? How do you train with video? How do you train with DL? I'll skip all the debate, but my personal belief is that you should train with video first. And the reason why you should train with video is for a few reasons. The first is you have no idea what the anatomy is. Like, you can look at all the textbooks, you can watch all the videos you want, but the truth is that until you're in there looking at the anatomy, you don't really know what you're looking at. Now, you could look at DL and by yourself, you could self-train, but wouldn't it be better if there was a large screen that was in front of you that your preceptor can look at and say, okay, you see, there's the base of the tongue. And right just distal to that, there's the posterior pillars. That's what we look for. Let's advance in a little bit forward. Up, there's the tip of the epiglottis. You see those down there? Those are the arytenoids. So by looking at the screen together, you're learning the anatomy in real time. And so now you could really understand what you're looking at as you're moving through your airways. And then in time, I believe the next thing to do is then to turn the video screen away and see if you on your own can identify the anatomy with the safety of someone looking at the screen as you're learning. And then ultimately, I think the ultimate skill set is that you're doing the intubations all on your own using DL. Now, I will say everything I just said right there is with standard geometry blades. There are hyperangulated blades, but I think that's actually a whole separate skill set. I believe it's a whole different procedure. Everything we're talking about here is video and standard geometry. And the other thing I would say for people who are learning is I would deep dive into the bougie. I often see that as, do you carry bougies pre-hospital?
Yeah. I just made a video about that the other day. So yeah, please go for it. Go in.
Yeah. I often see people think about bougie as being like the rescue device. It's the difficult airway device. And that may or may not be true, but let me ask you this. When is the best time to practice that procedure? Is it when you have your first difficult airway, when the adrenaline is pumping, when you're bouncing around, when sweat's pouring down your face? Or should you be practicing that early on the, anticipated easy airway? The person who is like skinny neck, skinny habitus, where you could see the cords. And I would argue because it's a fine motor skill, you should practice on those airways first. And then this way you have the dexterity that you need if you have a difficult airway. So those are two things that I think might be helpful for people when they're first starting their airway journey. It's certainly the way I teach my residents and my fellows locally here.
So one video I saw from you that really was fantastic. Talk about how holding the blade, the difference in the skill. I had a video on that. Maybe you can share that with our audience.
Yeah, I'm looking to see. I don't have any.
You don't have one next to you?
Oh, of course I do. Of course I do have a blade. Hang on a second.
Got it.
What kind of resuscitation do I be without?
Oh, there we go. There it is.
So I think the video that you're talking about is one where, holding the blade like this versus holding the blade with fine motor skills. And I just see this over and over again. And I see this with doctors because that's who I train. But I would bet that correct me if I'm wrong, I'd bet that pre-hospital people make this mistake as well. Again, adrenaline situation, you need to do the airway. People's reactions are to clutch it like they're holding on for their life. And what they're doing is they're doing brute force, and they're going in and they're trying to find airway anatomy with brute force. You don't have fine motor skills like this. I would ask you, can you take this and write your name? You probably couldn't. But if you hold the laryngoscope like this, like you hold a pencil, and then you're going in and you're looking for all your structures and identifying them, and then once you get into your vallecula, you find your place, you adjust your grip back here where you still have a little bit of force, but you still have some fine motor skills, then you're able to better manipulate the airway. But the sort of like cave person approach of going in there and doing things, you'll get the airway sometimes, but when you really need to get the airway in the difficult situations, it'll be very, very hard because it's a fine motor skill. So Rich Levitan, who's my airway mentor, always calls it epiglottoscopy, not laryngoscopy, because you're doing fine motor skills to find the epiglottis. Because once you find the epiglottis, you know where you are. But it's fine motor skills, fine manipulations of the tissues. And if you do that from the beginning as you're learning, I guarantee you that those airways that were difficult become less difficult over time. There'll still be difficult airways, but far fewer.
I love it, man. Fantastic. And I think the biggest point there is I think everyone's so focused on, obviously, like you said, just trying to be quick. Obviously, you want to be quick. Obviously, that's the whole point. We understand that. But like you said, the adrenaline's going, and you're just so focused on this, getting the blade down there, but you're just missing the whole point of you need to slowly find the anatomy. And I think that's something that we can definitely, focus on more. Just an overall EMS education. Every education is like, you got to go slow and find the anatomy as you go down. If you start with that from the beginning, then it's obviously going to help a lot. And thinking that it's like they say, fine motor skill versus brute force, just like, it's that really hit home. Obviously, someone who's done intubations, when you hear that, it's like, that was right in the money, man. So that was a fantastic tip.
Levitan, another quote from him that I love is slow is smooth and smooth is fast, right? And so what it means is that just taking your time, focusing on the next step is probably better than anything you can do, and it'll actually make you faster. And, I take over for airways that go bad on my trainees, right? And when I take over those airways, all I can tell you is I'm not doing anything different than they're doing. I mean, they're in there, they kind of go in there, they're looking around, they can't see anything. What am I doing? I'm just going slow. I'm taking my time, I'm identifying the anatomy. And I would argue that to me, initially, it seems like I'm going slower, but because I'm being more patient and diligent with it, ultimately the procedure winds up taking me less time. Because what happens if great, now you're in the vallecula, you can't see anything, you don't know what to adjust. That's taking you more time than taking your time finding the anatomy and getting it right on the first pass. I mean, I could talk about this all day long, but I really believe that for me, looking back when I first started Airway, and really any procedure, the difference is that taking my time and understanding the incremental steps and what it takes to have a successful procedure versus focusing on just getting the procedure done. If you focus on the incremental steps, you'll be much more successful than just focusing on like, I got to get the tube in the cords or this person's going to die. But it takes time. It takes maturity.
Moving on that, is there any other things that you like, for example, right? This is a great point you brought up. So let's say, you have someone underneath you on your team and they're going in doing an intubation, they can't get it, right? So like out in the field, right, we might have two paramedics, and let's say someone goes in, can't get it, pass it over, right? Change something. Do you kind of have like an internal checklist when you're dealing with a difficult airway? And if so, like, what is that? That'd be awesome to share with our audience.
The first thing is the patient properly positioned. That's my first question, So again, I'm taking over an airway. So, I might not have been there from the beginning. If I'm supervising the resident, I was there from the beginning. Are we getting our axes all lined up? If it's someone who's obese, we know about the ramped up position, right? Ear to sternal notch, getting that optimized. That'd be one of the things that I'd be concerned about. The next thing is that, I start over again. Let's come back out. Are we able to identify the base of the tongue, the posterior pillars, the tip of the epiglottis? Have we gone through those steps? If we have and we still don't see the airway, then at least can we find the epiglottis and figure out what's what? If we can find the epiglottis, then we know where the vallecula is. It's right above that, and then we can get in there. Now we know underneath that piece of tissue that's called the epiglottis are the cords. We just don't see them yet. I just gave myself a thumbs up. All right.
Yeah. There you go.
that apple. But the point is that I know where the cords are. They're under this epiglottis. So what do I need to do? I need to do some manipulations. The first thing that's underutilized is advancing into the vallecula a little bit further to get that hyoepiglottic ligament, which runs north and south. And if you can engage that, that'll pull up your epiglottis a little bit more. Maybe this person needs a little hand under the occiput and lifting their head up a little bit to get that axis, that view in better view. That's my next step. And then the third thing that's such a great trick that I don't see a lot of people using at all, and I mean this across the board, is external laryngeal manipulation, ELM. This is not crike pressure. This is not pushing down on the crike. This is having someone with a gloved hand put their hand on the larynx and you putting your hand on top of them and moving it around until you find the view, pushing it around. Maybe it's down, maybe it's to the right, maybe it's to the left, and then holding it there, saying, okay, I want you to hold pressure right there. And now you see the larynx in view and advancing your tube. Those are the steps that I usually go to. And I got to tell you, most times that does the trick for my patients.
So that was fantastic. So it sounds like one of the biggest things, obviously, we could pass on from this is one of the key points was when you have some of those easier airways, like we talked about, go for the bougie, not going to hurt. Is that something you kind of recommend to your residents too, to kind of just get used to it?
Absolutely. And there's studies that actually say that bougie first approach has much better outcomes in general. So there are some people that are saying every intubation should be done with a bougie. Like if you have a procedure that's like life or death, which you could argue that intubation, once you push those medications, that person's life is in your hands. Why would you not use a tool that would secure the airway? But anyway, I digress. That would say bougie first, at least when you're training, so you get familiar.
I love it. So we've gone through some of the main things I've gotten down here. So let me go into the thing I wanted to ask you about earlier. I'm just curious about it, right? So obviously one thing I talk about a lot, so obviously paramedics, right? ACLS, PALS, like that's like cardiology, pharmacology. It's basically like our bread and butter, right? It's cardiology, pharmacology. So I'm always talking about, okay, let's say, for example, we're at a cardiac arrest, patient's found on the kitchen floor, we work the cardiac arrest right there, we're going through it. Let's say they show up and they're in PEA or they're in asystole. Well, ACLS, not that many steps until we end up at the H's and T's, right? The thing about the H's and T's is, as far as EMS, we can go through them. Some of the things, like a lot of the H's we're already kind of doing, right? So like hypoxia, hypovolemia, we're already kind of treating these things just during the code, right? And then some of the other ones, like we mentioned about earlier, so where my question came from with, like cardiac tamponade, it's one of our T's, right? So I'm curious, how do you, in hospital, obviously you have more tools at your disposal, how do you kind of go through H&Ts with your team at a cardiac arrest? And like, what do you look for? And maybe even if you can share like a case where you uncovered one and maybe, sort of treat it. I'm just curious about that because we, obviously in the field, we don't have all the tools to go through each one and treat it if we see it. So I was curious about that.
And this is why I'm such a huge proponent of ultrasound, because I'm going to be honest with you, I think the H's and T's are just crap. It's a great way to teach. It's a great framework for people to organize their thinking. But ultrasound You already mentioned it. Like hypothermia, you really just have to touch the patient, and it's like, okay, hypothermia excluded, right? Hypoglycemia, you're excluding that with a finger stick or that. We can go through all of it, but you're limited with the H's and T's with the patient in front of you. But with ultrasound, think about all the other things that we are in the H's and T's that you cannot diagnose in the moment without ultrasound. So, we're talking about tamponade. We're talking about a massive PE. Is this person having MI? Does this person have a tension pneumothorax? These are all things that, I would argue there's no way pre-hospital or even in the hospital without ultrasound that you're going to do. You're just going through the motions. You're doing the code. Some intern has their little ACLS card and they're reading off all the things, and it's a big game, but there's a patient who's laying there, and it boggles my mind that there's still resistance to using ultrasound during codes. So for me, the probe goes on the heart, and I'm looking at the pump, I'm looking at the pipes, I'm looking at the tank. The pump, I'm looking to see if the heart's squeezing. I'm looking at the right heart squeezing, if the left heart's squeezing. If the right heart's not really squeezing, but the left heart's really squeezing, I'm thinking about, is it a PE? If there's a gigantic amount of fluid around the heart, well, it's tamponade, and I got to drain that. I'm not going to wait till the end of the code to stick the needle in like traditionally is done. I was like, let's go right now. I know what the problem is. Let's fix it. And so on and so forth. When it comes to the tank, even that, I got to say, during arrest, is we're already giving fluids wide open. So, unless you're thinking that the person is having a hemorrhagic shock, which I've found in some medical codes, the person who has an overdose of Coumadin, and now they have a big hemothorax in their lung, you would not have known that unless you put the ultrasound probe on. I don't want to hear people saying x-rays and you would have auscultated it with the lungs. That's all bullshit during a code. During a code, you are hyper-focused on just reversing any problem. And so looking with ultrasound, looking at your lung spaces, looking in the abdomen would help to exclude any hypovolemia from shock causes. And then pipes, just simply to say, you can look at the femoral veins to look for a DVT. If you think the person might have had a PE that broke off, you can look at the aorta, although I will tell you, during a cardiac arrest, extremely hard to look at the aorta, but something that you might want to try. So I don't want people to walk away from it being like, I'm not doing the H's and T's anymore. Look, if that's the only tool that you have in your pre-hospital, sure, go through it, but realize the limitations of it. But if you can get to the next level would be to use ultrasound as part of your code. And I can't tell you how many codes that we've gotten ROSC just because we found the underlying cause that I personally would have never found if we're just sitting there with like a laminated card just trying to read things off. It was the ultrasound that saved those people's lives.
I think that's a soundbite right there. I think that's the one. I think that's the one. That's the one. That might be the one I start with the video with, I think. So no, fantastic.
It's
man.
true. It's true. And again, that's why I think I mean it sincerely. If you're in a hospital system that doesn't use ultrasound, you just got to keep fighting. You got to emergency medicine. Just to give you some reference, I was a resident in 2003 when I first started, and ultrasound in my county hospital in Brooklyn, they didn't want to let us do ultrasound. They didn't want to let us do the FAST exam, right? They said ultrasound is for radiologists. Okay, so 20 years ago, ultrasound's for radiologists, and we said okay. So then whenever we get a trauma in, because we're a level 1 trauma center in Brooklyn with the Knife and Gun Club, we'll call your resident in every single FAST exam. And we had 20 traumas that night or so. And the resident the next day complained to their chair and they said, fine, you guys can have the FAST exam, but nothing else. You can. So my point is that you just got to keep breaking down the door and you will get what you want eventually. It's all about patient outcomes. It's not about attitude. It's not about ego. You and everyone else who listens to this podcast is out there just trying to save lives and make people better, bring them back to their families. And so we should have access to all the tools that are available to us to do that.
Yeah, that's what I was saying earlier. So from my perspective, all I've heard is what you said, which is just amazing things of using it pre-hospital. So do you know why there's so much pushback? Is it just like from the radiology side, or just what are your like, or something different?
I think it's a lot of.
It sounds like a no-brainer. Sounds like a no-brainer. Like obvious.
I think it's a lot of gatekeeping. I think that there's a cost, obviously, that's associated with it. There are some pre-hospital systems, that you all work so hard. I have enough friends who are paramedics to know that you guys are working doubles and triples and short staffed. And so that's a limitation. So now we're going to say, oh yeah, let's get some more technology. That's going to cost us some more money. I'm sensitive to that. But at the real root of the problem, I think, is definition of what ultrasound is. There are people who say we should have ultrasound pre-hospital. But what does that mean? Does that mean that you're going to be doing like looking for wall motion abnormalities in the left ventricle pre-hospital? Or are we going to do a quick point of care thing where we're just looking for lung sliding on each side? So I would recommend, and I'm sure some smart people in these big pre-hospital societies are already doing this, but there needs to be a definition of what ultrasounds are you going to be doing pre-hospital. I would say, again, I would say to start things going forward, I would say the things that you should do pre-hospital would be to look for a pneumothorax, look for lung sliding, because that is extremely simple and extremely reliable. Look for pericardial tamponade. Look for standstill, cardiac standstill during a cardiac arrest, and then be able to do a fast exam. And start with those. Get good at those. Make sure you can master that. And then once you get those, you start layering in more things. I don't think that the pre-hospital ultrasound is going to be what we do in the emergency room. And what we do in the ICU is not what we do in the emergency room. Point of care ultrasound is to answer specific questions in specific arenas. So you have to ask yourself, look, I'm pre-hospital. What do I need to know that's going to make my patient better instantly? Not to become a master at ultrasound and do everything. It's what do I need to know? What questions do I need to answer to take my next action, the next part of the algorithm? And if folks can do that, I think it starts to get a little bit clearer what pre-hospital ultrasound is. And then hopefully there's more buy-in across different systems. But that would be my, again, I'm not in the policies and procedures for pre-hospital, but hearing the chatter, that's what I would do.
Yeah, you pretty much hit the nail on the head with that, because what you just described there, going through everything, is exactly what I've seen work really well. So we're on the same page, man. So I might have to make a video on this at some point, because that would be that would be awesome. Maybe we'll have you on for that. That'd be pretty sick too.
I'm so passionate about it. I'm always like, anything I could do to help. I'm working on doing a pre-hospital ultrasound course for people if they want to join. It's not quite ready for prime time yet, but it's my passion. It's my belief that everyone should have access to the device. We just have to define what it is. So I'm always happy to help spread the word for ultrasound.
I love it. Let us know when it's live, man, and we'll definitely talk about it. Right. So last thing here, I always ask, is there anything that we didn't cover that you want to talk about? And if so, I'll leave it to you, man. The floor is yours.
I can only give you the interactions that I have with folks online. I have a deep respect for pre-hospital folks, probably more than anyone else in the hospital. I'm not saying that to pander to your audience. I'm certainly not saying it to pander to you. It's absolute respect. I worked in Brooklyn. I rode along with Fidney, during 9/11 and during, the Knife and Gun Club in Brooklyn. I went into some of the apartments that you folks have to go into, pulling people out of the craziest spaces, pulling people out of the craziest twisted wrecks of cars. I have so much respect. And so anyone that gives in the hospital that I see giving pre-hospital folks a hard time about, like, oh, they got a 21 gauge in the finger, or, oh, they couldn't even cut off the pants of this person. I'm like, you don't know. You just don't know what they do or what they go through. So I want to start off by saying how much respect I have for you folks. And I think as an emergency medicine and a pre-hospital team, we work so well together. And all we have to do is figure out the little nuances. We already talked about the, handoffs, getting the people in the stretcher to the bed, waiting for a proper handoff to happen. I think there's a lot of debate that happens sometimes, again, about mechanical versus manual CPR. I think that's a debate we probably should have a lengthy discussion on. Airways. And this happened actually just last night. I put up a little meme that was talking about, don't stop chest compressions for intubations, just put an LMA in or put a supraglottic airway in. And of course, there were some folks in pre-hospital that says, this is our opportunity to keep our skills up to date. Doing a supraglottic airway takes away those skills. I get that 1,000%, but I just have a problem with saying we're going to do less good care for our patients to maintain a skill. And I think with all the high fidelity simulations that we have available, that maybe we can get around that, or maybe we could find another way to improve procedural success. But those would be the things, and they're minor things. They're minor things that we can discuss. But those would be the things that I would say would make the already amazing relationship even better. But I have to ask you, because I'm coming at it from the physician end, why don't you tell me the things that us in the emergency room or intensive care could be doing better for you folks? Because again, I'm not ivory tower. I know that we can do a lot better, even myself. So give me some advice. What can I do better?
Yeah, I 100% agree on that. So everyone, have you drop in the comments down below what your reaction to that would be. Especially, I want to know about the ultrasound piece. If you're using ultrasound pre-hospital, let us know in the comments down below. I want to know about it too, because we're all learning about that. Want to know who's using it, who's having success with that as well. And the last thing I didn't write down, I actually, on a personal note here, because I don't see it as often. Are you guys actually using mechanical CPR in the hospital? So, for example, let's say EMS comes in, we're already using mechanical CPR, and a lot of times they'll then take them off and then go into just our hands, right? So, are you guys basically continuing mechanical all the way up, or for example, in your recess room or on the floor, you put them on mechanical? Are you guys doing that?
Yeah, in the emergency room, we have a device that we put on. I try to avoid brand names, but we put a device on. Sometimes what we do is we swap it out because it's the same device they carry pre-hospital, because we have our own EMS system. So we just give them ours and then we keep it and we recharge it. Up in the ICU, we have one, and so I use it whenever we have the opportunity to safely get the board underneath and get it connected, because again, I'm a big believer in minimizing those rhythm checks as much as possible. But yeah, I'll call for it to be in the room, and if we can find the opportunity to get it connected, I'd much prefer mechanical CPR to be happening on all my patients than just doing manual, just because I think manual is, we already talked about it, it's fallible and it creates a lot of noise and distraction and confusion.
Well, we're on the same page. All we got to do now is take over a EMS system, and we're good to go.
You let me know if you need anybody. I'm happy to join. That's awesome.
That's it, man. So, man, thanks so much for hopping on. I definitely we'll definitely have more conversations for sure. We were looking at about 30 minutes, and we went to 46 minutes on our first meeting here. So I'd say that's pretty good. So
look, I had a blast. I really appreciate you having me on. In fact, I'm so grateful for you having me on and for everything that all your listeners do. If you can give them a link, I'm going to give everyone access to a conference that we did in 2022. It's our Resuscitation conference. It was like a 3-day conference, like 80 lectures. You can just have access to it. Just go ahead, click on the link, and it's my gift to you as a thank you for listening, but also really a thank you for what you all do every day, risking your lives and making people better and bring them home to their families.
I'm looking forward to seeing that too. So link will be down in the description, everybody. And I will see you on the next podcast. Take care, guys. See you, brother.
Thanks.